To cast or not to cast? Let's now review the 15 research studies that may surprise you. To determine optimal recovery from a fracture, sheep who received experimental tibial fractures with a 3 mm gap were randomly allocated to one of two groups: complete immobilization for 6 weeks or daily doses of controlled axial micro-movement. They concluded that the application of the daily micro-movement and loading was osteogenic, meaning it potentially improved bone healing. In the group of sheep in which micro-movement was not allowed, there was a delay of a further 2 weeks before callus was visible on radiographs. Fracture healing process might be enhanced if appropriate mechanical stimuli could be applied to the fracture site during the healing period. I realize this is a study from 1985. Don't worry, I'll move up to 2021. These first few days or weeks are a crucial period in which to reintroduce the normal mechanical stimulus to osteogenesis. Again, osteogenesis being bone formation. In another sheep study, they concluded that the application of the higher number of daily cycles resulted in an up to 10-fold greater amount of periosteal new bone formation on the compression side. Instead of sheep, this time rats received experimental tibial shaft osteotomies. Some were either stabilized with an external fixator or exposed to various controlled loads. They concluded that the compression and control groups exhibited improved healing in terms of mechanical strength and stiffness, and a more mature callus mineralization compared with the distraction group. Moving away from sheep and rats to human studies now, 80 patients with tibial fractures were immobilized with an external skeletal fixation device. They were then randomized to either a rigid fixed mode or axial micro-movement mode. They found that both clinical and mechanical healing were enhanced in the group subjected to micro-movement. In this case series study, patients with isolated stable lateral malleolus fractures were treated not by traditional 6 weeks of casting, but by a tensor bandage and advised to weight bear as tolerated. And guess what? The fractures all still healed within 6 weeks and patients regained their normal functions. This may be an important study to acknowledge, as being in a cast for 6 weeks isn't without any potential adverse effects, which we'll discuss later. Another study again showed that those post-stable lateral malleolar fractures advised on immediate weight bearing as tolerated had similar outcomes when compared to those immobilized and non-weight bearing for 4 weeks in a plaster cast. In another study, patients showing up at the ER post-stable lateral malleolar fractures were either immobilized and told to be non-weight bearing for 4 weeks in a plaster cast, or splintered and advised on immediate weight bearing and movement as tolerated. There was no significant difference in the amount of pain experienced or in the requirement for analgesics, and early mobilization was not associated with any complications, which is a really important outcome of the study. We therefore advocate early mobilization for these stable ankle fractures. In this UK study, almost 700 patients with stable ankle fractures were randomly allocated to either a traditional plaster cast or a removable splint. The finding was that no statistically significant difference in ankle function between a plaster cast and a removable fixed angle brace at 16 weeks in adults with an ankle fracture. In this study from Finland, patients with stable, non-displaced fibular fractures were randomly allocated to 6 weeks of cast immobilization, or 3 weeks of cast immobilization, or 3 weeks of a removable splint. Concluding, immobilization for 3 weeks with a cast or an orthosis was non-inferior to conventional cast mobilization for 6 weeks. In a similar study, a treating physician at a UK fracture clinic gave the patients the choice of 1. a weight-bearing cast below the knee. A functional ankle brace was the second option they had, and the third choice was just a tensor bandage and a regime of rest, ice compression, and elevation, the classic Rice regime. The authors conclude that it appears that when patients are given opportunity to make an informed choice, the vast majority opt not to have a cast, yet their decision to either be casted or not makes no difference in the fracture healing. Again, all three groups had the same outcome: a cast, a splint, or a tensor bandage for a non-displaced fracture. These studies also suggest that the use of removable bracing instead of casting may help reduce the incidence of symptomatic deep vein thrombosis, or DVT, in patients with ankle fractures. Other than DVT, 6 weeks of complete immobilization in a cast is associated with other potential complications, such as joint stiffness, muscle atrophy, compartment syndrome, thermal injuries, pressure sores, skin infections, and dermatitis. So far, we've reviewed the results of 10 studies that provide some evidence that complete immobilization and non-loading of certain stable fractures may not only be unnecessary, but may sometimes even be delaying healing. Let's review 5 more studies on the topic. You may now be asking, what about kids and fractures? What about the wrist and the hand? I look forward to seeing you at the next lesson, where we'll talk about to cast or not to cast. And we'll review 5 more research studies that may again surprise you.